My great pleasure to introduce the next speaker, me. I hope this day is kind of long. I'm on beat right now, so I hope we can make this interesting and interactive, and maybe kind of with the slideshow do question and answer as we go. And just before that, the lidocaine study we'll do right after this. We'll do it here. Okay, great. So let's go to the next slide. I'm going to talk, when talking about hypokalemic periodic paralysis and how to deal with it, we have three things that we want to talk about. Identifying the triggers, how do you deal with the acute attack, and then preventing attacks. And under those bullets, there's a few different things. So we'll go to the next. Identifying triggers. A lot of what I've come to know as a good management of hypokalemic periodic paralysis came from my own anecdotal N of 1 experience. But also, in speaking with people over the years, I don't manage anyone other than myself. I got, collected a decent amount of information about what's probably the right thing to do. One thing that I've found, and I know a number of other people have found, is identifying triggers by doing a diary. Whether you do it for 1 week or 2 weeks, it's uncertain what's the best time frame. But you want to document what kind of attacks you have, what part of the body, how severe it is. You can make your own little scale of 1 to 5. How long it took to regain movement, and how you medicated. And what I found when I made a diary is that I had a bowl of rice, and I had an attack. I had a bowl of rice on Monday, and on Tuesday I had an attack, and on Wednesday and Thursday I also had attacks. And I thought of those as separate attacks. But when you looked at it, that the next Tuesday I had an attack on Wednesday and Thursday, that maybe the attack wasn't just that one day. Maybe it was kind of 3 days, and it was just not fully gone away. Next slide. Also, you want to know kind of what activity did you do. Did you go jogging for a mile? Did you, sit sedentarily at your computer for a long time? Also, what foods did you eat? Did you have a high carbohydrate meal, a salty meal? Did you have alcohol that night, etc.? And then what medications you took, and if you forgot to take them or didn't forget to take them, you find different things trigger attacks. Other things that you might want to think about are infections. And maybe you don't have an infection in the 2 weeks you do the diary, but you want to kind of keep track of that. Diarrhea, because with diarrhea you lose potassium in the stool. Lack of sleep sometimes is a problem. When there's a change in weather, barometric pressure or cold, menstrual cycles, and these are all triggers that people kind of report. Not everyone has every trigger, so it varies from person to person. In terms of diet, also, in order to decide what's good to eat, you have to first realize that what you eat causes an attack. So I would have a bowl of rice one day and be fine the next day. And then maybe next week or 2 weeks I have that same bowl of rice. Well, a different bowl of rice, but the same rice. And then find that I was paralyzed from it. So if you look at it, the logical person says, gee whiz, I had rice, and one time I was paralyzed, one time I wasn't. That's not reproducible. It can't be the rice. But it wasn't the rice, and it's just that sometimes it's a trigger and sometimes it's not. And then, so it doesn't have to be reproducible every time to be a trigger. And that goes for sodium, for fasting, and other things. So high carbohydrates are bad. And that's my favorite pizza right there from Sal's Pizza in Marinette. It's the best pizza I've ever had. But it's a trigger. So you have to weigh. Sometimes, the enjoyment in life is so much from this food that you say, I'm going to have it, I'm going to pay for it, but the amount that I enjoy the food is worth it to what I'm going to pay for it. And so, with every disease, with every problem that's like that, with diabetes, I guess is a better example. But pizza, pasta, mac and cheese, too much bread, potatoes. The question is, are there better complex carbohydrates? Has anyone here tried soba or something like that, where maybe it's not just simple sugars and they can eat that, but they can't eat just spaghetti? No? Yes?
Not actually soba, but I'm taking a supplement called maltodextrin for weight gain. Surprisingly, it actually doesn't have the same effect as regular carbs actually would. Regular carbs make my blood sugars go up and down really bad and trigger attacks. But the complex carbs don't seem to do that for me.
Right. Okay. And then quantity plays a role. If you have a bite of something is different than having a whole bowl of something, and so that factors in. Next slide. What can you eat? Sometimes it's better to decide what you can eat rather than just say what you can eat. And it's best to find alternatives that of what you can. It's unlikely that foods high in potassium will obviate treatment. So a lot of people, initially naively think, oh, well, if I just eat a lot of bananas and drink Gatorade or something, that I'll be fine. Well, the issue with Gatorade, by the way, is that it's full of sugar and it doesn't have all that much potassium. So that's probably not a great idea for hypos. And I used to drink like a bottle a day of Gatorade for like 10 years. And finally I realized, like, wow, this is making me feel terrible. And I stopped, and it was better. I'd like put the potassium in the Gatorade, thinking that, anyway, okay. So one medium-sized banana contains 467 milligrams of potassium, which is 12 milliequivalents. Not all of it is necessarily absorbed. It also has 28 grams of carbohydrates. So you need to eat 6 bananas to get 72 milliequivalents of potassium. But that's a lot of carbohydrates, and that's like 1.5 pounds of bananas. So it's not practical. Next slide. Some people mention that if they take calcium or magnesium, that those supplement helps, and obviously potassium is a whole other subject. So how many people here take calcium and say that helps them? A couple of people. Any you want to comment on that? Or?
I take calcium because my calcium is low, which I assume is secondary to acetylzolamide.
Okay.
Yeah, I take calcium tablets and it helps periodically.
Okay. Shelley?
I take calcium and it's sort of like my potassium does.
You take calcium and it works like your potassium does.
Sometimes I get night if I can't sleep, I take potassium or I can sleep. And sometimes with calcium, do the same thing.
Okay. Excellent. Go one more.
My wife drinks a hot chocolate that's really rich in milk, and that's great every morning. And it's not with sugar. You use stevia or some other sweetener, but the calcium in that milk.
That's interesting. Okay. Next slide. So in terms of supplemental potassium, so obviously some people are kind of forced to self-medicate, and I'm not advocating self-medicating, neither here nor there. But the products are out there. They are what they are. You should just know what they are. So there's one called No Salt or New Salt, and I guess there are other brand names for that. It's in the spices sections of the supermarket, and it comes in a 3-ounce jar that has like 19 doses of 60 milliequivalents of potassium, and about 5/6 of a teaspoon is 70 milliequivalents. So it's there if you have to pull like a Harrison Ford fugitive kind of thing. All right, and potassium has many different dosage forms, and I used to think that there was one dosage form that was better than another dosage form, and I think the more we have larger number of patients that give us histories, it's going to be unique to each person. Some person is going to do real well with the potassium sustained release pill. Other people are going to do well with the fizzies. Other people are going to do well with powder and water, etc. So powder and water is good because you have a rapid spike of potassium. And it's my personal opinion, and maybe Frank, you can comment. If you have an attack and you just take a little bit, you're never going to get that spike in blood level that you need to switch the channels back. So I think it's helpful to have like a proper spike to change the electricity and then have the channels recuperate versus just adding little by little by little. Do you have?
I totally agree.
So Frank totally agrees. Go back. So The pre-made solutions are also good, and they probably work the same way as the powder and water. It's just a question of dosing. Sometimes they come in milligrams versus millimoles versus milliequivalents, and that can get very confusing. I always think in milliequivalents, and I try to convert whatever dose someone asks me into milliequivalents, and then I can see what's going on. The fizzy tablets are good, except they, they're a little carbonated, right? So I don't know what people's experiences are. When I'm really badly paralyzed and I drink something that makes me want to burp, I don't feel well from that. But are people like pro or con on that? Anybody? No opinion? Okay. The sustained release tablets tend to cause a little more gastric irritation because it's a pill. It just sits right in the stomach, and it's just dissolving in high concentration right in that spot in your stomach, and it can cause some irritation. In terms of using intravenous, we like to administer it in mannitol, not D5W, which is sugar water, or normal saline, which is salt water. And since you don't need like a whole liter of mannitol to give potassium, you can give it in just 100 cc's, which is a small little bag. It's not going to cause osmotic shifts like in your brain. It's not going to drag out all the water out of your brain into the blood if you use just a little bit of mannitol. How much mannitol? Well, so usually you put like 10 or 20 milliequivalents in a 100 cc bag. But the issue is, if you really have to do like 5 and 6 and 7 bags, it may become an issue. If it's just 1 bag or 2 bags, probably not an issue. Okay, then in terms of counter-ion, people ask, does it matter whether it's chloride, bicarb, gluconate, or citrate? And if you go by the theoretical, acid-base balance in the blood and stuff like that, you can make a theoretical argument for or against one of these counter-ions, but I think in all practical matters, you're only taking a very little bit of either chloride or bicarbonate. You're probably not going to change things all that much. Frank, do you have a preferred counter-ion? Not really.
I just have one comment. If you get kidney stones from Diamox,
Yeah?
the citrate version, it kind of irritates the digestive system a little bit more, but the citrate will prevent the kidney stones. But you can also have, as another doctor pointed out, make yourself some lemon juice in the morning, that's citrate.
Right.
Or eat cabbage, that has
So kidney stones, depends on what stone you have, depends on kind of how you want to, what thing you take to dissolve out the stone. And so I'm not an expert about, which stone is which. I know that acetazolamide causes a specific kind of stone. Do you know what stone? Oxalate?
Oxalate.
Okay, so calcium oxalate. And in that case, I guess citrate is good to dissolve that out. So that's definitely a good point. The oral route is always preferred rather than intravenous, because intravenous you can overshoot. Oh yeah, when you get the prescription for potassium, obviously a lot of doctors, they don't like to give that much, and so if you know that it takes 3 packets of 20 to get you out of an attack, what I write for myself and what I think people should be written for is, imagine having an attack, twice a day, every day. So that's 6 packets a day times 30 is 3 times 30 is 180. So they should give you in one prescription the maximum amount. Because the worst case is to have 5 attacks and then you're out of potassium for the month. Where are you with that? So there has to be some working with the physician that you're responsible, you know your body. Once they understand that, well, if you take 40, I know that your blood goes up this much, and they've done the test. Anytime after that, you probably can use your own judgment. Okay. In terms of oral management, dosing is important, and I don't know that we've really studied a standard, and it's probably worth studying in a proper clinical trial. But anywhere from 0.5 to 1 milliequivalent per kilogram seems reasonable. So you do a large bolus. If that large bolus doesn't work, you don't want to do another large bolus because you're going to start to get into overdosing situations. So doing smaller increments every 30 to 60 minutes is probably reasonable. And of course, any one individual person, maybe doesn't apply, but for the general rule, I think it's a fair thing. And I would be comfortable only giving more than 100 milliequivalents if you check the potassium in the blood. So if you finally have to give 100 in someone who normally takes 40 or 60, you want to have a blood potassium before you start throwing in more, because there are some cases where you can throw someone from hypo into hyper and they get different situations. And I think it's fair that a maximum of 200 milliequivalents is probably what you'd want to do. Yeah. I mean, some people take enormous amount. How many people here take on a regular basis, every day, 100 or more? It's like a lot, right? So even my preconceived notions. How about more than 200 on a regular basis? Just one. So two. 150. Okay, so so there's a handful that need more. Let's go to the next. In terms of intravenous management, you want to do IV potassium if the airway is compromised, or if you really feel that there's an impending arrhythmia. So doing 10 milliequivalents every 20 to 60 minutes is good. You want to not overshoot. You want to get the patient out of danger, not necessarily perfectly correct the potassium level by IV. The second you can safely go back to oral, it's better to go back to oral. And you never want to put more than 40 to 80 milliequivalents per liter. So you don't want to have like too high a concentration of potassium in the bag because it really irritates the
nephrologist is not being excreted from the kidneys, at least in the tests that they've done.
right.
That's what it is.
So look, it's a good question. There are theoretical explanations and there's real explanations, and like many of the things, the real explanations we don't know so well. It definitely, there have definitely been studies on giving people chronic potassium and seeing what happens to their urine, and so maybe it'd be worth revisiting those on the internet, and we can maybe talk later. You can submit and ask the experts, and I'll look into it. Then in terms of brands, different people have different brands. I just threw a couple up there. I use the Chloricon. Other people like the Efricay, and there are many others. In terms of chronic therapy, you have a few choices, and this we don't have to spend too much time on, but you have carbonic anhydrase inhibitors, and there are 3 flavors of those now on the market: Diamox or acetazolamide, dichlorphenamide or Daronide, which is not on the market but in studies, and then Glauctabs, which is methazolamide, and all of these things are also used for glaucoma, and that's what they're really primarily indicated for. They happen to work in periodic paralysis. Then you have other therapies which are potassium-sparing diuretics. And, just in light of Dr. Layman-Horn's lecture, I wonder if we, any pharmacology course will label these drugs as potassium-sparing diuretics, but we probably could also give them another name in terms of, you're naming it by a mechanism of action, but that's not the mechanism of action necessarily that's operative in periodic paralysis, maybe. So, but it's a nice way to think about them. They're potassium-sparing diuretics. One is Inspra or eplerenone, another is aldactone, and then diurinium is triamterene. And actually, on the package insert of triamterene, so I'll get to that in a second, but diurinium is not diazide. Diazide has triamterene plus hydrochlorothiazide. So for hypokemia periodic paralysis, you got to be careful not to be taking the combination drug that can make you worse. Question?
My comment is about the next one. I realize I'm a little ahead of time, but I'm so excited about this that I have to share.
Okay.
It's amelioride. We found that with amelioride, my wife has been very successful with it, but there are 3 different makers of amelioride in the United States, and of the 3 different makers, one of them has great effects, and the other 2 have some additional thing in the pills that knock her out, and it's been a very eye-opening experience to find that that's the level of sensitivity that we're at. But
yeah, that I'm sure at least a handful of people here have found that even with Diamox, different manufacturers of Diamox, sometimes they respond to one and not to the other. I can't explain that per se. I think that it's worthwhile to look at the ingredients of each one, the excipients, the things that are not the active ingredient. See, well, this one has lactose, and this one doesn't, and this one has magnesium stearate, and this one doesn't, and you may find a difference. So amiloride is yet another potassium-sparing diuretic, and I would say that some people may not respond well to Inspra, but they may respond well to triamterene, and they may not respond well to triamterene, but they may respond well to amiloride. So, I mean, Frank, how would you approach when to switch someone from one to another to another?
So because all these agents have side effects, I prefer to combine these substances. I think that's much better to keep the side effects low. But many doctors do not agree with this concept.
So for example, so that's interesting, right? So you take something like acetazolamide, which wastes potassium, but it helps hypo for other reasons. And then you might combine it with spironolactone, which spares potassium, and also, by the way, may help hypo by other reasons. And so you can use these things in combination. So that's actually an excellent point. Then there's experimental stuff, which I don't know too much about, except that anecdotally some people say they've used these things and it's helped them. But there's a drug, 3,4-diaminopyridine, and another one, panacetyl, that people have used. In terms of general points, there, you know, some people might naively think, well, I'm really badly paralyzed. Not only should I be taking my potassium, but I should also be taking my Diamox. And it's actually not good for acute attacks, the long-term diuretics, okay? An optimal dose will require trial and error, and some of them may even worsen symptoms. You'll usually know this by 1 week, if not sooner. How many people have taken, for example, Diamox and it's had a negative effect on them? And just call out, you know, about how many days before you knew that it was an immediate, or 1 day? Immediate. How many days do you tolerate it before you're like, forget it, I'm out? That's just one time and you were done? Because some people try to be good patients and continue with it and they feel worse and worse. And
I stayed on it for 4 months.
you stayed on it for 4 months, but you felt it was making you worse for 4 months?
I think they were.
Wow. Okay. So anyway, you'll know pretty quickly if it's not good for you. I think that's fair to say. But if one fails, you may try another. Now, Frank, if someone does poorly on acetazolamide and it really makes them feel bad, you're hesitant to put them on dichlorphenamide, right? Or you would try it.
Dichlorphenamide is not on the market, so we have a problem. So we can use it.
But like in theory.
In theory, take an aldosterone antagonist.
Yeah, so I mean, so that's the same thing. I think that if you do poorly on a carbonic anhydrase inhibitor, I probably wouldn't switch to another carbonic anhydrase inhibitor unless there's desperation. I would probably try first a different mechanism of action, like potassium sparing.
I would like to add something.
Yeah.
All patients who worsening taking cover anhydrase inhibitors improve when taking an aldosterone antagonist.
Oh, really?
Could you repeat that?
So this is a periodic paralysis pearl, PPP. That if you do poorly on those people who do poorly on acetazolamide, historically each of those people have actually improved when they've taken either spironolactone or a Clarinone.
Does that count true if the effects of the Diamox wear off after taking it for a while?
So if the Diamox, you did well on Diamox for the first year, and after the first year it starts to wear off, do those people also predictably get better with spironolactone? No. Do you want to?
Probably who worsening when taking cover anhydrase inhibitors have specific mutations, and in these mutations, aldosterone antagonists always help. If it works, but only a year, this is a completely different problem. This is probably enzyme induction or whatever.
Yeah.
But principally, in these patients, carbohydrate anhydrase inhibitors help. But in these patients, also aldosterone antagonists can help and can be combined.
Great. So, right, if someone's failing, if someone does well with acetazolamide, then it tapers off, you may probably be able to just add on, you know, the Clarinone or something like that.
Reduce the dialogue.
And reduce the Dynamox in addition. But still have both on board, correct? Yeah. Was there a question?
Jake, that's exactly what I did within the past 6 months.
Okay.
Exactly. That the Dynamox seemed to plateau after a while, and then we tried spironolactone, didn't do anything, went to the Inspra, dropped down the Dynamox to the dose in half with the Inspra, and it's made a big difference.
Okay, so you dropped the Diamox in half, added the Inspra because the aldactone didn't work, and now you're doing well.
Right.
Okay, great. One more.
Well, just adding potassium, if you're not on any of those medicines, will just adding potassium improve things if you're having paralysis with your problem, or will you have to have?
Okay, so the question is, I'm newly diagnosed hypo, I'm virgin to therapy, and do I have to start on one of these, carbonic anhydrase, or can I just tough it out with potassium alone? That's your question?
Yes.
Okay, so I'm of the feeling that these drugs alter the disease course, and I'm of the feeling. I don't have proof one way or the other, and Frank, you can tell your opinion too. I would think that I would prefer that patients be on something in addition to potassium, what you do with potassium, different people are different. Some people, they have a daily dose of potassium no matter what, and that may be because they're on, some potassium wasting thing. Like if you're on acetazolamide every day, you're going to be peeing out potassium every day. You're going to have to supplement that even if you're a normal person. And some people may take potassium only when they have an attack. But I think that probably all the time they should be on one or another of these, Clarinone or acetazolamide.
Yeah, I think the combination of potassium and drug is good. Just in the case that the drug has major side effects and the patient can well survive with taking potassium only, then it's okay. So.
Yes, of course. If there's a situation where the only drug available is acetazolamide and it does you wrong, then of course don't take that and just manage with potassium, but that would be like a suboptimal thing. Okay, so this was the next slide. So in terms of discussing carbonic anhydrase inhibitors, the dose can be as little as 62.5 milligrams, and maybe even less than that, and as high as 1,000 milligrams per day. For Daronide, usually it's 12.5 to 200 milligrams a day, and for the metazolamide, it could be anywhere from 50 to 300 a day. The side effects are going to be tingling, confusion, kidney stones. Some people, they worsen the paralysis attacks. And if anyone has COPD, it can cause an acidosis because you're peeing out bicarbonate, so it makes your blood more acidic. And if you can't, blow off your carbon dioxide, it also makes your blood acidic, so the combination may not be good for the person. Question?
Can you comment on the dose of those things for children?
No. Can I comment on the dosing for children? Every yes, this is for adults. Every drug usually has a corresponding pediatric dosing, and they have a Harriet. What is it? Yeah, is it Harriet Lane? Yeah. Okay. So Harriet Lane, there's a pediatric textbook, Pharmacopoeia, with pediatric dosing, and so we look it up. Hopefully.
Just to follow that, for pediatric dosing, are these kind of drugs more related to weight issues, or is it more maturity of internal organs that might vary on that?
Other physicians in the room? Is it more of a weight-based thing, or is it more that the pediatric kidney can't handle it, whereas the adult kidney can? I think it's a weight thing.
Pediatric kidneys are pretty powerful.
Yeah, I think it's a weight-based. I think it's more of a weight-based issue. And in terms of drug interactions, high-dose aspirin and these can cause problems, and if you take steroids, you can get hypokalemia. For aldactone, dosages can be anywhere from 25 to 200. Guys report breast enlargement and tenderness because it also blocks testosterone. So it doesn't only block aldosterone, but it blocks all the other similarly structured steroids. Again, the question is, should you give potassium with a potassium-sparing diuretic? And I think the answer here with periodic paralysis is yes. There are drug interactions. If you take aldactone and triamterene, in the package insert of triamterene, there were 2 deaths reported. Now, whether those were because of this combination or not is unclear, but maybe this particular combination I'd try to avoid. Then the question is, it's also probably okay to give with potassium and with an ACE inhibitor in hypokalemic periodic paralysis patients. So an ACE inhibitor is like lisinopril, and that lowers the blood pressure and makes you hold on to potassium. And usually you wouldn't give an ACE inhibitor and spironolactone together to a regular person, but in our situation, maybe it's okay. Then Inspra is like a new version of spironolactone, and it works like aldactone without the hormonal side effects. And overall, it's well tolerated. The theoretical problem of hyperkalemia, as Frank mentioned, he feels that it's probably not such an issue. I would agree with that. And you want to avoid in type 2 diabetics and if people have severe renal dysfunction. And then if you're taking, there are certain drugs that are cleared by a certain liver enzyme in your body, you have to watch for those drug interactions. Triamterene, we don't have to spend all that much time on it. It's another choice. There aren't really too many problems unless you have gout. And amiloride also, you want to avoid in renal insufficiency and diabetes, and there are drug interactions as well. The combination therapy, we mentioned Inspra or spironolactone and acetazolamide, and both of the above with potassium. You may just initially, when you're initially starting such a regimen, probably good after a week to check the blood potassium and the blood pressure and maybe other electrolytes just to see how they're being affected.
Several times.
So hold on.
Several times. So the first 4 weeks, once per week, and then once per month, and after a longer time, once per 3 months.
Great. So the idea is that whatever regimen you have, if it's new, you just want to know what's going on. What is it doing to your body? Once you have an idea of what it's doing to your body, you can be a little more comfortable about just blindly continuing. In terms of other aspects of periodic paralysis, having a safe physical environment cannot be overemphasized. At the bedside, regardless of weakness, you should have things that can rescue you. So having potassium there, having water in a plastic bottle, a glass shouldn't be on the table because sometimes when you're weak, you don't have the best muscle control. You're reaching for it, it falls on the floor, it's broken. Then you have to go and try to get another one, and you can imagine the whole mess. You want to have a telephone by the bed, and you want to avoid a direct exposure to air conditioning or open windows overnight. Because if that blows on you, you start shivering. That shivering is the exercise, and then the rest after exercise, becomes a trigger. You want to never be caught without potassium. You always want to have it on your person. Put some in your jacket, put some in your work bag, keep some in your desk in the office. So you're never in a situation where you're like, oh, no potassium, and I feel that. You want to avoid slippery rugs and other obstacles, because if we're lumbering around the house and you can't quite lift your leg, you trip over the rug, that can be disastrous. And it's probably helpful to have handrails in the bathtub. And the other thing you can consider is having a buddy system, someone to check in on you, and I'm sure that a number of us have that currently. In terms of pregnancy and hypo, I thought that was a good picture. So there is hope, you know, if you're pregnant. First of all, I guess this warrants a whole other survey. But how many people, when they were pregnant, their attacks worsened? And then how many people, when they were pregnant, their attacks got better? So, okay, that's tough. They're kind of neither here nor there with that. But anyway, if you need to maintain therapy during pregnancy, Inspira is pregnancy category B, as is amiloride. The other options are pregnancy category C and probably should be avoided if possible. And obviously, it's a discussion to have with the obstetrician. A lot of people report muscle pain and in hypokinetic paralysis. It's something that's not well studied. It's something that I'm really curious to understand what the real incidence is. And I'm also really curious to understand what works for people, because that's a question I'm frequently asked. And I have no, it's not really in the classical references, right? So the question is, what do we do for it? So how many people here, and the question is, what is muscle pain? Is it just, do you feel sore? Is there like stabbing pain? But how many people have some sense of pain after or with attacks? So like a good number. And this pain, let's say you take potassium, you can move again. How many still have muscle pain? Okay, and then what do people take medicine for this, or you just live with it, or?
I have a heating pad I use almost every day, and I sometimes, when my legs are aching and stuff, even in the middle of the night, wake up and your legs are working and stuff, I'll take it, and it's always plugged in wherever I'm at, whatever, and I'll wrap it around my leg, and I'll wrap it to the other leg, or I'll put it on my back, and I'll just kind of move it around my body, and sometimes that helps a lot of the cramping and pain if I've already taken all my potassium and
Right.
everything else I can do, and other supplements like calcium, magnesium, and all that.
Yeah, and other than heating pad?
I'd be curious if anybody else does this. I don't have any pain during attacks. It's afterwards, sometimes even the next day. Like sometimes the attacks are kind of a nice reprieve from the muscle pain. It happens, that's common.
My wife, if she fights the attack or tries to power through it, and she can actually do it by getting the muscles moving and by walking through or powering out of it, then she can give herself a worse painful attack the next day, or when she wakes up the next day, it hurts a lot more than if she just says, okay, I'm having an attack, and just lets it go.
Right.
And stops the fall. Magnesium seems to help you.
Magnesium helps you?
Stretching,
Stretching?
gently.
I take extra potassium, and I put my bed in channeling bed.
Oh, so you take potassium and you put your bed where the blood is rushing to your head? Yes?
I find that like if I start to feel weak, if I try to move or do some type of exercise to get my muscles moving, that sometimes helps.
Okay, so kind of like gentle exercise. What about just like Advil? Anyone just take Advil?
I take Advil myself, and also giving it to my little boy since he was about 3, and we noticed that he was getting sore, and it has a really dramatic effect on his immunity.
This is, I'm sorry, which one?
Advil.
Advil. Okay, so we've had we've had the gamut. So, okay, just someone. Ibuprofen is the, okay. Okay, next one. In terms of perioperative management, so this we discussed a little bit in the other session. The question is, you're going for surgery, you're scared out of your mind, and what do we do about that? And so, other than meditation, the real things are, when you go into surgery, they make you fast. They strip you naked. They put you in a cold room, with some little blue sheet. And then they pump you with D5W normal saline. So like you have all of these triggers all at once, and then you have the stress of the surgery. So one thing that you just have to mention to the surgeon is, how can we mitigate all of these triggers and safely still do the surgery? Some of them they'll be able to make go away, and some of them they won't. It's important that they check you frequently. Especially when coming off anesthesia, coming out of anesthesia, and when you're off the respirator, because that's your most vulnerable time. You also have to let them know to beware of inadequate anesthesia. I know one patient once mentioned in one of the conferences that they had a surgery. They were not anesthetized, but they were out, and they couldn't move. So the doctor thought they were anesthetized and like did a surgery on them. So yeah, not cool. So if you get like that, you have that conversation. It's a very striking story. It just raises the attention of the surgeon. In terms of eye doctors and dentists, epinephrine is the trigger. Most often when you have injected anesthetic, you have lidocaine and you have epinephrine. And the epinephrine they use because it constricts the blood vessel and makes the lidocaine stay in that area a little longer than getting washed away by the blood. So, but if you can delete the epinephrine, it's just that the lidocaine will wear off a little sooner, and that's fine. But ask them to use plain lidocaine. Now, it's very rare to be allergic or even to have an attack induced by plain lidocaine. Does anyone here have just, if they do plain lidocaine, that they get attacks? Okay, that's good news. And then sometimes when you dilate the eyes, you use these beta agonists, which are epinephrine-like molecules, to dilate the eyes. So one patient used a lacrimal plug to avoid absorption of the epinephrine. So you have tear ducts that go from the corner of your eye into your nose, and if you put the eye drops, they'll drain from the tear duct into your nasal mucosa and get absorbed. So if you put a little plug in there, and the eye doctors can do that, that's one thing that can help. In terms of thyrotoxic periodic paralysis, the term is thrown around a lot. I guess we don't see it a lot. I haven't encountered too many people with TPP in the PPA. All these letters. But like hypokalemic periodic paralysis is such a mouthful, you know? It's so hard to talk about. It's caused by hyperthyroidism, and it is more common in Asian males, but you can see it in anyone. And the therapy in this case is propranolol, which is a beta blocker. And you know, epinephrine is a trigger, so it makes sense that propranolol should help these attacks. Potassium also helps, and thyroid ablation is ultimately the good cure. And acetazolamide in these patients sometimes worsen the attacks. And in terms of, let's see, hold on one second. Go like one or two more. Yeah, so what I wanted to do is not focus so much now on hyper, because tomorrow we're going to focus a lot of the day on hyper. I just want to see if, hold on, I'm going to go up. Up. Yeah, okay, so go down, down, down. We may well be at the end of this. Anderson to Will, we probably should speak on a little bit. This is you know, a familial issue with potassium channels, and you can get hyper or hypokalemic periodic paralysis associated with long QT syndrome or other arrhythmias. And then there's associated skeletal abnormalities. Again, not all of them will be in all people, but you'll have sometimes wide-spaced eyes, low-set ears, webbed fingers, a small head or microcephaly, and clinodactyly. Now, Dr. Lehman, I don't have all that much experience with Anderson to Will. Do you find that, and maybe we can throw it out to the group, are the attacks predominantly hypo, or do you really see hyper, or how does that?
Yeah, currently that's a mess, we can't tell you. So some are hyper, others are hypo, and we thought it depends on the mutation, but currently it does not depend on the mutation. And in some families, one are hyper and the others hypo. So it's currently it's a mess.
Sorry about that. The main symptoms are the same as with any periodic paralysis, but you'll also have palpitations, and I guess there are maybe more atypical attacks. I've always, in my mind, viewed, you know, plain old hypokalemic periodic paralysis, the attacks being mainly kind of a gradual onset. You run up the stairs, you sit down, and like within a couple of minutes, your legs have just stopped working, and now it's like, okay, I can't get up. I can talk, I can move my arms, but I can't get up. You know, and that's kind of that's a regular attack in my mind. So the Anderson to Will can sometimes be way more atypical, way more sudden in onset. You can't open your eyes, that kind of thing. So I think that remains to be clarified. I guess after this I'll be talking a little bit beyond my scope, so I don't want to really mention too much more. But I know that Lori has had an issue where we other Lori. Yes, where she had twitching in her arm, and she had a severe attack of weakness. She was twitching in her arm, and the issue was this was a manifestation of the attack, but it's also exercise, and that may have been triggering the weakness. And the way we broke that cycle was to give a little bit of Klonopin at the suggestion of Dr. Terwill over the phone. We were in a hospital in Las Vegas, I think, and that broke the attack, and then she walked out of the ER. I thought that was pretty cool. So it's these are kind of hypotheses and ideas.
I was going to say, I get jerking and twitching, and I come in the ER sometimes and I had an attack, maybe go flaccid and something might jerk or something. Sometimes I would take small doses of Klonopin because I don't have any seizure meds right now for a general epilepsy. So some of my seizures, and some of them kind of mimic, like that said, seizures, the little jerking and twitching, and that's what they do for me is maybe give me a little more, I would say, benzo.
Right.
And it does seem to help, and also I start feeling more stable. Whether it's epilepsy and this going on, it seems to help balance my system.
The big picture, and I guess this kind of speaks to the issue of if you don't have a diagnosis, are you the kind of physician who's going to say, okay, well, I observe these symptoms, I'm not really sure why they're happening, let me give a trial and error of this medication that in theory seems to work, even though I don't have a set diagnosis? Or do you go by the book and say, look, I'm not giving you anything, I want to do no harm first, and I want to know what I'm dealing with before I give the medicine? So it depends on which doctor you're dealing with about who's willing to try things.
I have the same twitching, and Klonopin takes care of it. It almost feels like a seizure sometimes, but I'm always cognizant and the head's working, so it can't really be a seizure.
Okay.
Right?
I would let these guys come. Yeah, go ahead.
There are some forms of encephalitis. These are very new results from the last years, and they show the patients are conscious and they have this arm jerking, like the seizure. It's a part of a seizure, but it doesn't affect the consciousness.
Okay, in the back.
I had the movement that mimics seizures, but all of the benzos had adverse effects on me and made me much, much worse. The Klonopin and the Ativan and anything else they could think of to give me to stop them just made them keep coming. And then I went to having them from once a day to twice a day to a couple times a day.
Right.
So.
Okay. One more in the back.
I have been almost like epileptic type jerking with my sons. About 6 months ago, my neurologist decided to try Keppra, and has completely taken care of it.
Really? So you've had epileptic type jerkings, you've tried Keppra, and it helped. Keppra is an anti-seizure medication. Okay, let's see what next slides are in store. I don't even know my own presentation. Because it's a different one than I thought I'd put there. But anyway, with Anderson to Will, the cardiac issues are really important. That's again another area where I wish I were more familiar. But being in dermatology, unfortunately, we don't deal with the heart that much. But you should have EKG monitoring. A lot of people have AICVs to prevent fatal torsade de pointe from long QT issues. Since long QT is associated with this, and indeed is classified as one of the many long QT syndromes, there are a long list of drugs that one should avoid with this syndrome. And there are websites that have these lists. And the drugs for arrhythmia are a little bit tricky when you have long QT syndrome. So again, really requires a cardiologist who's interested in this.
Do long QTs always show up on a basic EKG, and are they always seen as abnormal?
My understanding, correct me if I'm wrong, that long QT is always abnormal if it happens, and it should show up on the regular EKG even if there isn't an attack. But I will let Frank talk to that.
Yeah, it depends on the heart rate. So
for example, if it's a
it can be that you can see it at a certain heart rate at rest in the praxis. So when an ECG will be written, and at a different time, at a different heart rate, then it might occur.
Okay, so I mean, so that also is a little bit slippery then. So depending on how fast your heart's beating, it may or may not show up. Someone in the back wanted to comment.
I was just going to say, for me, with anesthesia will, it doesn't show up half the time on ECGs, and then it shows up, and then it doesn't show up, and then a bit of BT. So it just depends on the blooming.
Right. Lori? No, that Lori.
Yeah, my quantity only during attacks is long, yet my daughter is always borderline after resting all the time.
So Anderson to Will syndrome is a little bit slippery. So for mom, it's only during attacks. For the daughter, it's any time. And for yet another patient, it's sometimes yes, sometimes no. So that's just another tricky thing. Paramyotonia congenita. I almost want Frank to just present this slide. I don't know. Are you comfortable talking just for a second about this?
Next time.
Next time. Okay. Anyway, you have muscle stiffness that worsens with exercise, so it's paradoxical myotonia, and it worsens with cold. And serum potassium in this case is normal. You have muscle stiffness that's followed by weakness, especially in cold weather, and there would be no warm-up phenomena. And the main triggers are possibly the same as those for hyperkalemic periodic paralysis in terms of cold, and cooling and heavy muscular work in this case are the triggers. Things that alleviate attack acutely are warming the patient. It should relieve the stiffness. There's no real therapy that will relieve the weakness. And therapy, if you have hyperkalemic periodic paralysis in combination with paramyotonia congenita, then the same therapies that you use for hyper would be addressed for the paramyotonia. So.
I have a question. When is stiffness? Is the stiffness, and when is it myotonia?
So I'm sorry, when is this?
Well, my face, when I'm in this kind of weather, it can be like this.
There's, okay.
And it's not really paralyzed, but it's like facelift.
Yeah. So is that myotonia you're saying, or is that just stiffness, or, I mean, if someone's face is, and you have, which, we're not sure what you have.
Hypo.
Hypo, probably. So, I don't know, Frank, do you want to comment on facial stiffness in the context of hypo, or?
Yeah, it's not usual. So, but I would like to add something here. I think it's not true to say no therapy to relieve weakness acutely. So you can prevent stiffness and weakness by local anesthetics like antiarrhythmics like mexivitin. So perfectly. And some patients, before an exposure to cold, like playing guitar in a church, they take mexivitin for 2 days and then they can play in the cold church without any stiffness and weakness.
Oh, wow. Okay, good.
Is there a genetic mutation linked to paramyotonia congenita?
Is there a genetic mutation associated with paramyotonia congenita?
Yeah. Sure, these are SCN4A mutations, so sodium channel mutations, in a typical area of the protein.
Okay, next slide. There are other entities, potassium-sensitive myotonia, which is also a sodium channel problem, where you'll get intermittent generalized muscle stiffness without weakness, not worsened by cold, but worsened because of eating potassium, and sometimes rest after exercise, and sometimes succinylcholine anesthesia. and preventing attacks of this condition, also mexillatine. In terms of myotonia congenita, it's a chloride channelopathy that's primarily muscle stiffness, and the main triggers are sudden exercise and sudden noise. Things that alleviate the attacks, in this case, repeated movements of the stiff muscle, called the warm-up phenomenon, will help you get moving again. And things that prevent attacks, there are a number of them. Again, mexillatine, when you're talking about myotonias, the mexillatine is probably the drug that should be thought about.
Unfortunately,
Yeah, go ahead.
unfortunately, taken from the market. Only in Japan it's available. So, but there are other drugs which can replace the mexillatine. The flecainide and the propafenone.
Okay. So flecainide and propafenone are other drugs that replace mexillatine. Mexillatine only available in Japan. Okay, so I guess, does anyone have any other questions or things they want to add? Just for a couple, and then we'll call it a day, I think.
I take that mexillatine, and I got it in Ohio, so.
Oh, really?
Yeah.
Okay, so maybe this is a recent development, but okay, if you get it, great.
Appropriate, yes. And it works nice. Remaining.
Oh, it's probably just yeah. Okay, well, anyway, I think people are maybe getting restless. What I would say is we want to do this lidocaine thing. I don't know, Nikki, do you want to just say how it's going to go down, or?
For people who want to test for the lidocaine sensitivity, this will be good information for deciding on some of the genetic studies and so forth, and we hope to use it eventually as a good criterion to see how a gene is going through the family. And so the people that would be of the highest priority would be people who think that they have lidocaine insensitivity, because this will provide a good test for it. We've had several of us who know that we are normally sensitive to lidocaine and found that it has a pretty fast and noticeable effect. So people who have been tested for genes and have no known gene would be a high priority. People who think that they're sensitive to, that they're resistant to lidocaine. People who are being tested tomorrow with their blood, that might be helpful. People who have large families and think that they could trace lidocaine insensitivity through the families. And then anybody else who wants, we have a bunch of it, and I can tell you what the procedure would be, just so you can decide whether this sounds like something you want to do or not. It's a gel, and we put basically a few drops on your finger, and you paint it on your tongue, and you try not to swallow it, and you leave it on for a minute or so, and then we have like napkins, and you can just sort of dab it off, and then you'll either feel it's numb or you won't feel much of anything at all. And so we have a consent form that you can fill out, and in addition to what we have on the form, we'd like people, and by the way, for those who actually read every line in the form, there's a whole bunch of other things we're not going to do. We're only going to use the lidocaine, and we're only going to use the subjective impressions, the stuff about sharp versus dull. We tried it, Frank and I tried it yesterday, and we weren't convinced that it could tell us anything. So, but the subjective sense was pretty striking. And so the things we'd like to record in addition to what's on the form is write down, does this work? Did you have an effect from this or not? And if you have a known mutation in a channel, to write down that information. So those would be the two things to add.